Thanks for having me. I'm Christine Capone. I am a cardiac intensivist at Cohen Children's, and I'm going to be discussing the cardiovascular manifestations and implications of the SARS-CoV-2 virus, focusing on MIS-C. This graph is representing admissions to CCMC hospital. The blue is patients who were affected with SARS-CoV-2, PCR positive, had active viral infection. The red are what we now know to be MIS-C. Their presentations vary, and we're learning more about these each and every day. The most recent publication out of JAMA across multi-centered PICUs, just looking at active PCR positive SARS-CoV-2 virus infection, shows a different presentation from that of MIS-C. In this paper, you can see the predominant presentation and symptom is respiratory, with very, very few having cardiovascular manifestations or requiring vasoactives. MIS-C, on the other hand, on this paper that came out last week, looks at 58 children across multi-centers in the United Kingdom. And what they had found was their presentation with seropositive antibodies to SARS-CoV-2 virus is presenting different from those in the primary infection. Respiratory symptoms are the minority of presentations, and actually GI symptoms and shock and LV dysfunction is the predominant manifestation. So focusing in on what cardiac findings we can see, particularly in MIS-C, it's decreased cardiac function, decreased LV function. Any myocardial dysfunction is anywhere from 50 to 65%, depending on the reports and the studies that you look at. The function is mild to moderate, and here is some representations of that mild to moderate dysfunction. 33 was mild and 24% was mild in our cohort, and that predominance is what is seen in the other publications that are out there. We had no severe LV dysfunction, although up to 12% has been reported in the literature. We also can see pericardial effusions. We can see this in about 45 to 50% of patients, depending on the study looked at. They're usually trivial to small, as seen down here. Here is another manifestation of the pericardial effusion, again, being very trivial to small. And this clip is as a reminder that it also can have arrhythmias. These arrhythmias can be sinus bradycardia, heart block, first, second degree. They can have SVT, atrial arrhythmias, and we've seen some non-sustained ventricular arrhythmias as well while they're in the hospital in their acute phase requiring vasoactives. The thing that everyone's most worried about is the coronary abnormalities, as the presentation, as Dr. Schneider had mentioned, is quite overlapping with Kawasaki disease. The GI symptoms are abnormal, but they do have some rash and conjunctivitis that are teeing off, but these kids tend to be older. And when we do take their echocardiograms, we see these dilated coronaries that you see in the bottom of the screen. Any coronary artery dilation is seen in 48% or 50% of patients, and that can be true across studies. Lack of tapering, so where they just look prominent, but they don't actually measure dilated, is anywhere between 24 and 41%. Dilation is a z-score 2 to 2.49, and that's seen in 9% of our patients, whereas aneurysms are seen in 15% or a z-score greater than 2.5. 14% of either dilation or aneurysm, they do not distinguish between the two, has been reported in the literature. So what is the way or the pathophysiology believed to be behind MIS-C and the LV cardiovascular manifestations, coronary dilation that we see? Right now, there's multifactorial cause. Cytokines, either caused by direct infection by the SARS-CoV-2 virus into the myocardium, can lead to localized destruction and myocyte necrosis, leading to a myocarditis. These cytokines pull in a kind of adaptive immunity, and then adaptive immunity creates immunoglobulins, can make immune complexes, and those immune complexes can give you a vasculitis, such as seen in Kawasaki's disease, and give you a microangiopathy. That microangiopathy, coupled with patients who have abnormal coagulation profiles, such as elevated D-dimer or thrombocytosis or thrombocytopenia, depending on what we see, can have a localized vasoconstriction or vasculitis, and that vasculitis can lead to poor myocardial perfusion. When myocardial perfusion is compromised either by, again, the cytokine release, the stunning direct infiltrate, or by vasculitis, then you add on top of that the increased demand that's kind of seen in the shock-like state, the tachycardia, the fever, the extra burden that the heart has. We see to further decreases in perfusion that can lead to conduction abnormalities and changes in your heart function. The inflammatory process that we see here, the cytokine release, the immune complex formation, is not only seen in the heart, it can be seen elsewhere in the body. And it can see multi-system inflammation, hence the name multi-system inflammatory syndrome, COVID-related or in children. And that Kawasaki-like feature, or that mucocutaneous vasculitis, where you see bulbar conjunctivitis or cracked lips, you can see lymph nodes, and that those GI lymph nodes are responsible for the GI symptoms that we see, like a GI vasculitis, often terminal ileitis, and then the vasculitic skin rash. So then how do we tell the difference? Is it MIS-C or is it another inflammatory syndrome like Kawasaki, or are they one and the same thing? Do they overlap? So there's this recent paper published in JEM that we showed earlier, looking at 58 children across centers in the UK. And they compared these children with an earlier retrospective cohort out in San Diego with Dr. Burns, looking at her Kawasaki illness and Kawasaki shock illness. They also compared toxic shock syndrome through a toxic shock study group in the UK through the PERFORM consortia. And they compared the phenotypes and the lab values of these patients. And what they found is that patients with MIS-C, or what they call PIMS, they're older. They're older than KD and KD shock and toxic shock. MIS-C or PMIS patients have a predominant lymphopenia. Their counts are quite low, and it's quite a hallmark. And their CRP is markedly elevated compared to KD and KD shock, and is close to toxic shock, but markedly different from KD and KD shock. Their platelets are much lower than anticipated in Kawasaki and Kawasaki shock. Their D-dimers are quite elevated, and here we don't have the D-dimers for toxic shock, and we only can compare to KD and KD shock. And their troponins are also markedly elevated, and that correlates with the degree of LV dysfunction that we do see in the MIS-C patients in comparison to what we typically see in KD and KD shock. So here at Cohen's, we developed a treatment pathway and a guideline to help us identify and treat these patients. How this guideline came about was looking at our experience of patients and as they came to us, and now the literature has kind of borne this out a bit. Whereas if you had fever greater than 38 for 4 days and GI symptoms or any of those mucocutaneous changes that we talked about, rash, headache, conjunctivitis, oral changes, we wanted to think about these lab profiles that are becoming telling that you have the inflammatory profile consistent with MIS-C. And those lab profiles are a CBC, a CRP, ferritin, looking for coagulopathy in your D-dimer and fibrinogen, looking for other organs that are involved from your shock, looking at your CMP for liver dysfunction and AKI. We want to know if there's other organisms are involved to make sure that we are looking at the immune-mediated pathology that we do think is driving the MIS-C, and it's not another bacterial infection, another virus. That's why we send our blood culture and RBP. And we look at EKGs to see if there's any arrhythmias or conduction system disturbances. If all of these are normal, then routine care, continue your workup in the emergency room as you otherwise would. If there's some abnormalities, this would spark an infectious disease consult and a cardiology consult in our institution. How we risk stratified the patients also comes from these labs. So patients who require the ICU that you see here on the orange bar graph to your right are those who required vasoactives in the unit, and they were profoundly lymphopenic. So not only is MIS-C lymphopenic, but the more lymphopenic you are, that correlated with the need for vasoactives in the ICU. Albumin was much lower in those patients who needed the ICU in orange as compared to those who were diagnosed with MIS-C who were on the floor, and those are shown in blue. And the CRP was much higher, the median over 200 in those who had vasoactives as compared to those who were on the floor. And the pro-BNP was much higher than those who were on the floor. The pro-BNPs here exceeded that we see in toxic shock. Even in septic shock, we know they can be elevated in those illnesses, and they are much higher here. Their D-dimers are much higher if they require the PICU and vasoactive than those who do not, and their ferritins are as well quite high, often median over 1,000 for those requiring vasoactives. So MIS-C is ultimately diagnosed with fever, the clinical profile that you see here, with inflammation, CRPs or ferritin that are elevated, and one of the following three phenotypes: a cardiogenic or distributive shock with multi-organ failure, no Kawasaki features, classic Kawasaki features with the listed criteria, and incomplete Kawasaki disease with the listed criteria. If you had fever and inflammation, but you didn't fit the phenotype, or your inflammation was borderline, we observed you in the hospital and trended labs and trended your fever curve. Thinking about this, you had MIS-C now with shock, MIS-C with typical Kawasaki features, MIS-C with incomplete Kawasaki features, and possible MIS-C. Those with shock or decreased function were admitted to the PICU. Those who had normal function but had evidence of Kawasaki-like features were admitted to the floor. They were high risk if they were admitted to the PICU, and they went our high risk treatment pathway. We further risk stratified and dosed our steroids according to their severity of illness. So low dose vasoactive that you see on the right side of the screen was like 1 per kilo, looking at like 60 as a max. 60 as a max per dose, whereas higher dose pulse steroids were used in those with escalating vasoactives, multiple vasoactives, EKG changes, the sicker cohort. Because there is a lot of overlap and similarities with Kawasaki disease, some, not all symptoms, but having at least 2 or 4, and because of the inflammatory profile and cytokines sometimes match those seen in Kawasaki disease, we treated with part of our algorithm in Kawasaki's to look at IVIG and aspirin and anticoagulation, as we know that that has effect in Kawasaki. Again, not saying these patients have it, but having profiles quite similar, we used it. We really wanted to control their inflammation, and so anybody who had fever greater than 24 hours from the IVIG infusion were trending CRPs and ferritins and their echoes. If their echoes were worse, or if their CRPs and ferritins were up, ferritin particularly over 800, they would get a biologic, in our case anakinra, which is a useful adjunct in Kawasaki disease, as well as secondary MAS, which both Kawasaki shock can have, in addition to other inflammatory syndromes. So we thought we were getting both with this treatment regimen. If they were admitted to the floor, the high-risk pathway on the floor was for those who had normal function, but they may have coronary dilation greater than 2.5, or less than 6 months of age, and they had the Kawasaki features. This high-risk pathway on the floor mirrored that of this low-risk pathway in the unit. And again, really controlling fever and inflammation until after 24 hours of IVIG, really trending these labs and seeing if there are cardiac changes by echo or increasing inflammation that would require addition of other medicines. If they were low risk, we just started with IVIG and moderate dose aspirin. And again, if they were febrile, CRPs, ferritins, echoes to see where they went. Oftentimes, second doses of IVIG are employed in Kawasaki disease to try to avoid the use of biologics. Here, if we were greater than 50 kilos, we made a collaborative decision with our infectious disease colleagues, in addition to cardiology, our hospitalists, pharmacy, everybody involved, to say if you're over 50 kilos, another dose of IVIG is quite an osmotic load in addition to a volume load that some of these patients may not need. And so if you were greater than 50 kilos, but you did not have coronary dilation, we just added a steroid. If you were over 50 kilos with coronary dilation, we then added a steroid in addition to Remicade. The steroid, especially in coronary dilation, becomes important to be tapered over time in the Kawasaki literature to help at least try to prevent. And then in terms of anticoagulation, everybody got aspirin, some needing Lovenox, and that was in conjunction with our hematologist looking at ROTMs, looking at their coagulation profiles, particularly those with D-dimers and fibrinogens greater than 1,000, EKG changes or echo changes that would indicate starting them on Lovenox, looking for kind of like microthrombi or poor perfusion, secondary to either cytokine release, the microangiopathy, or immune complex mediated vasculitis. Ultimately, what this algorithm led to, this guideline led to, was our experience where 100% of patients identified got IVIG, only 30% requiring a second dose. 70% were high risk and needed methylprednisone. Biologics were used in about 20%, with anakinra being the one that we leaned on the most. Anticoagulation with aspirin and Lovenox was 88 and 42%. And the 88 was because not all of them up front were recognized as the Kawasaki-like features, and that kind of adapted over time. The Lovenox was used again because they were hypercoagulable. They had elevated D-dimers and fibrinogens. These are some ROTEM studies that Dr. Spella might refer to later that showed that they're hypercoagulable. They had a low Adams TS13, and they were at risk for thrombi. And given that their coronary changes, we tried to make sure that we perfuse their coronaries as best as we can, given the microangiopathy. Interestingly, in our cohort, and hopefully to be published by our hematologist, we did not see any evidence of thromboses in our group, not in the coronaries, not in the lungs, and so this literature is constantly evolving, but this is what we used. 79% of our patients required the PICU, with 76% of them requiring vasoactives, with a median vasoactive score of about 10. None of them required ECMO. 52% required a little bit of oxygen or BiPAP, where 6 were intubated, but again, that was for hemodynamic support. Nobody really had lung respiratory pathology, as we showed earlier. The median length of intubation was about 3 days, with length of stay total being about 4 days. And to date, all have been discharged home alive from the PICU. By discharge, almost all function had improved. 27% went home with mild dysfunction who were previously moderate. And by 2-week follow-up, I'm really happy to say that Dr. Mitchell and myself follow these in clinic, and they all have normal systolic function. The coronary abnormalities can persist, but they, in our cohort, have been improving. Very few were dilated with a Z-score of 2 to 2.29. They were just improving. There were no aneurysms that we saw, nobody with a Z-score greater than 2.5. So our patient who came and presented like this in the hospital and was treated with IVIG and steroids, aspirin and Lovenox, looks like this at 2-week follow-up, where you can barely see the LAD. And this treatment is trying to prevent aneurysms that we see in Kawasaki, which I show here on your right. So in summary, MIS-C is a spectrum of disease and phenotypes, really. Fever and inflammation is just one of them, with some organ dysfunction and features, and there's no Kawasaki features in that category. Those are your cardiogenic shock, multi-organ failure patients. Fever and inflammation with Kawasaki features, or fever and inflammation with shock and plus or minus Kawasaki features is another one. These kids tend to be older. They have more GI symptoms, vomiting, diarrhea. There's more intense inflammation, as we saw in the comparison paper of CRPs being elevated. In our cohort, ferritin was elevated. We're looking at the D-dimer they're more hypercoagulable. There's a lot more cardiac dysfunction and shock than we're used to seeing in KD and toxic shock phenotypes. There's more aneurysm development early on and across phenotypes, and these aneurysms appear out of proportion to the inflammation. We do know that they respond to anti-inflammatory agents, IVIG, steroids, anakinra, Remicade, but which ones to use? Every center is doing something a little bit different, and so as more data and more patients come, we'll be able to look back and say if any of these did help, and moving forward, if this does come again, prospective studies might help tease apart and what of these drugs seem to be the most beneficial. And long-term follow-up of these patients to see if there's any risk factors that predicted their long-term outcomes. As I said, right now at the 2-week follow-up, almost everybody has normalized their function. I don't see any dilation of their heart. And in regards to their coronary arteries, everybody's improving with no aneurysms, and so time will tell. I really want to thank our multidisciplinary team here at Cohen Children's, the pediatrician who refer and who've been on calls to help us kind of identify and screen cohorts to infectious disease, emergency medicine, hematology, my colleagues in intensive care, the hospitalist service, and cardiology. I really, really want to thank everybody.
So just in terms of the background of this illness, we know that we're all probably familiar now that by mid-March, when the UK was in the deeps of the COVID-19 epidemic, there were multiple sites that are reporting a bunch of similar cases of febrile children with what seemed to have an inflammatory illness. They all had similar clinical features of fevers, sore throats, headaches, rash of the conjunctivitis, or gastrointestinal symptoms, and many of those kids ended up requiring critical care because of shock or organ dysfunction. And they all showed evidence of inflammatory syndrome, specifically elevations of ferritin, CRP, and D-dimers. And then, although they were in the throats of acute COVID, these children mostly had no evidence of acute SARS-CoV-2 infection. Rather, they had serology positive for symptoms. So they on the 27th of April, this is obviously that first case definition where many of us are familiar with at this point, where they presented the first definition of the Pediatric Multisystem Inflammatory Syndrome temporally associated with COVID-19, and have subsequently published some data on that I think was already presented. And then we had a couple of first few case series, one from on the left here from the UK, and then on the right from Italy, kind of describing cohorts of similar children. Then the World Health Organization came up with a case definition that they shared with us on the 15th of May, which included a fever for at least 3 days, and then multi-system involvement, elevation of inflammatory markers, and then evidence of COVID-19 infection or exposure. And then the CDC came up with the MIS-C definition around the same time, which was very similar, other than only requiring a fever for 1 day rather than 3. So just to give a sense of what the COVID-19 burden has imposed on pediatric ICUs, at least here in North America, these are data from yesterday from the Virtual Pediatric Services, or VPS site, which is a large multi-institutional PICU database of quality metrics that can be used for research as well as benchmarking. And from at the beginning of this COVID era, at this point, 183, I believe, institutions have submitted data, and up to with 600, and 32 patients having been input. But what's more interesting is that once MIS-C became known and a unique syndrome in and of itself, many institutions within the cohort have been contributing data on this. And if you see here, what I've highlighted is that 40% of all PICU patients in this cohort that have COVID-related illness are due to MIS-C. So that shows really the burden that MIS-C has imposed on pediatric ICUs. And of course, also it kind of hints to the severity of illness that these children often present with. And these are some of the early publications. I know Dr. Capone went over the first large study that was just published last week in JAMA, which was the UK's cohort. But here in the US, there was on the left here from the Children's Hospital of Philadelphia, they published a case series of 6 patients with the syndrome. And then recently, a week and a half ago, our colleagues in the city here, in the city, reported on 17 patients. And then just the other day, our institution just published 33 patients in this cohort. And then of course, next to us here on the right are other colleagues in a group of hospitals here in New York also describing 33 patients. So we're learning more, we're sharing information. This is how we're really making progress as a group. So this is our curve here, which here at Cohen Children's, and this is all COVID-related infections in our hospital. You can see clearly this early peak of acute COVID with these black squares, and then as the peak tails off, about 3.5 to 5 weeks later, we see this increase of MIS-C patients, which really helps to delineate the acute infection from this what we are considering a post-infectious phenomenon. We have currently reported, I think it's 58 as of yesterday, patients to New York State Department of Health. Our average age range is similar to what we've seen in other cohorts of 8.2. 64% of our children have been male, and the race breakdown are fairly similar to what our current demographic is in our catchment area. Looking specifically at some of the clinical characteristics of these kids, what I think we've all understood at this point is that generally speaking, these are healthy children. These are not kids with underlying comorbidities or complications for other illnesses. These are healthy kids, other than there was a higher propensity of or incidence of obesity in our population of 39%. And in our region, our catchment area is about 18% obesity is what's in our is what our DOH reports. So a little higher incidence of obesity, which is what we've seen, of course, in the acute COVID infections in kids and adults. Only a few children had underlying reactive airway disease, however, didn't seem to contribute to these to the presentation. The children presented after 4 days of fever in general. 58% had neurocognitive symptoms, which include things like lethargy, irritability, things of that nature. As has been described, almost universally, these children present with gastrointestinal symptoms of either abdominal pain, vomiting, diarrhea. We know from other cohorts of children that kids have ultimately ended up getting laparotomies or other surgeries looking for GI sources, however, never finding a gastrointestinal pathology. 52% of our children had respiratory symptoms. However, as described a little bit by Dr. Capone, that these children's respiratory symptoms all seem to be related to hemodynamic or cardiovascular compromised rather than primary lung infections or lung disease. As mentioned, many of these kids, 3/4 of these children present with shock, which require either fluid resuscitation and/or inotropes or vasopressors, which is quite remarkable. 64% of our children have met criteria for complete Kawasaki disease, and of those who met complete Kawasaki, also 3/4 of them ended up presenting in shock. So again, really speaks to the profound hemodynamic involvement of these kids. Up till now, we are at 61% of our children have required ICU care. And what's interesting that after our first 33 patients that we just reported in our article, those kids, 79% required ICU admission. It turns out that these last few weeks, that the severity of presentation have been less, and we have some speculation as to why. But thankfully, many of these more recent kids have been treated just on the floors. The children, as mentioned, have stayed in the hospital for 4 days only, despite the fact of the high incidence of shock. Just relating the lab results that these children present with, it's a profound leukopenia that we often see, as we do in the acute setting. Mild anemia is often present. The average platelet count is 154. There have been multiple with thrombocytopenia as well, but the median was 154. As mentioned, the C-reactive proteins are remarkably elevated, as well as D-dimers and ferritins. The B-type natriuretic peptide levels are remarkably high, as well as troponins, as well as procalcitonins. And as also reported, and in common in other vasculitides, for example, or inflammatory diseases, hyponatremia is quite common. Specifically looking at our SARS-CoV-2 testing, 86% of the children were IgG positive for SARS-CoV-2, some of whom had not been tested at the time of preparing these, just because they were in the earlier cohort when testing was not even available yet, and they will be tested on follow-up in the infectious diseases clinics. Only 24% were PCR positive, and still unknown whether or not that was acute infection or just residual non-infectious RNA that's still present. When you combine the two, only 22% were IgG and PCR positive, but almost 80% were IgG positive with no evidence of SARS-CoV-2. And then organ involvement. What other organs get involved? Because this is a multi-organ syndrome, and as mentioned already, almost half the children had some evidence of abnormal coronary arteries, either dilatation or aneurysms, which thankfully seem to be getting better. However, that's a very high number, much higher than the typical Kawasaki population that we're familiar with. 21% have presented with acute liver injury. As we see in the acute COVID-19 infections, 70% of these patients have AKI. Thankfully, the vast majority have improved. Half the patients have required some type of respiratory support, more commonly just oxygen. Few have required non-invasive ventilation, and only 6 patients, or 11%, have been intubated. And as mentioned earlier, I do want to focus on this a little, is that the intubations have not been due to primary lung disease or lung pathology. It really are secondary to cardiovascular compromise. And those get intubated, they remain that way for 3 days. So just as a summary, what are the differences that we've noticed here with MIS-C compared to acute COVID-19 is that in general, the MIS-C patients are completely previously healthy. We know with acute infections, there are some comorbidities that increase the risk a bit. The MIS-C patient population really spans the entire pediatric age range and perhaps even into younger adults, unlike acute infections, which are typically, at least in our experience, have been a little older children. We know with acute COVID-19, we think of primary respiratory disease like pneumonias. However, in the MIS-C patients, the x-rays generally have been quite normal. And again, if ventilated, really require that for hemodynamic support rather than primary lung disease. There's been a quite universal elevation of inflammatory markers in MIS-C. Unlike in the acute COVID patients, there are a small subset of those that we consider the quote-unquote cytokine storm, where there is elevation of inflammatory markers, but it's not universal by any means, at least in children. And then lastly, with MIS-C, almost all of our patients are SARS-CoV-2 seropositive. Few are PCR positive, unlike acute COVID, which almost all are PCR positive. I think that will be my last slide for now, and I'll be happy to share, pass the baton to one of my other colleagues. Thanks so much for listening.
Thank you so much, James. We will return to questions at the end of the webinar. Again, wanting to encourage the audience to put questions in the questions section on the GoToControl webinar control panel. And with that, I think we will be switching and inviting the talk by Dr. Mohammed from Montefiore Hospital with a comparison for the adult population. Thank you so much, Dr. Mohammed. We're really looking forward to your talk.
Thank you very much. So I'm an attending physician at Montefiore Medical Center, and I'm going to be focused on the adult population and COVID-19. I'm going to talk about the hyperinflammatory syndrome in adults and thromboembolic complications that we have seen. I have no disclosures, and just to give you an idea of our Montefiore experience, at the peak of the pandemic, and that would be around April 12th, we had 1912 patients admitted in our system. 476 of those were ICU patients. We still had a lot of patients who were ventilated or on pressors on the floor due to overflow, but our ICU patients, including the PICU, were full of patients who were in refractory hypoxemia and refractory shock. So briefly, I wanted to go over the characteristics of COVID-19 in adult patients. I'm going to start with a cohort of patients that was, this is a study from New York City, where they looked at 5,700 patients that were hospitalized with COVID-19. And they noted that 30% of those patients were admitted with fever. 20% had an oxygen saturation below 90, 27% required supplemental oxygen at triage, and about 17% had a respiratory rate over 24. And COVID-19, as most of you know by now, is mostly respiratory disease with ARDS in adults. These patients, out of the cohort that was in New York City, 2634 patients were either discharged or died at the time of publication of the study, but there was about 72% of patients who were ventilated who were still in the unit at the time of the study publication. So I looked at the mortality and the ICU admission from the total number of patients rather than from the patients with the outcome. And you could see that 26% of patients overall required an ICU, and they had about a 21% mortality in all admitted patients, which is comparable to a retrospective cohort study from China from earlier this year, where 26% were reported to require an ICU, and they had about a 28% mortality. But I'm going to focus on hyperinflammatory response in adults, or as some people call it, secondary HLH or cytokine storm or macrophage activation syndrome. So we noticed that some of these patients would develop treatment-resistant pyrexia, and this is temperatures as high as 107 and sometimes 109 in a couple of patients that we have seen. That does not improve with Tylenol, does not improve with cooling, and we've had to start Arctic Sun or some hypothermia protocols that we use for cardiac arrest in some of those patients. At the same time, we would see acute worsening of lung injury with increased FiO2 requirements and worsening shock and increased pressure requirement. A new multi-organ dysfunction, including either a new AKI or worsening liver tests. We would also see, even if the inflammatory markers were initially downtrending, you would see that they would acutely start going up again. And that includes ferritin, LDH, fibrinogen, and D dimers. We would check those every day while in the ICU, or at least every other day, to kind of stay on the lookout for these for this syndrome. But IL-6 we would test whenever we suspect it, and we would always see an elevated IL-6 with those patients. And this is very similar to HLH that's seen in pediatrics, which you guys probably know more about. But in the adult population, the trigger is usually an infectious disease. This is not something new. It's something that has been documented multiple times, even pre-COVID. And the trigger is usually either infectious agent, a malignancy, or autoimmune disease. The most common triggering factor is viral infection, usually EBV. And this would result in T-cell activation, T-cell proliferation, and macrophage activation, release of these cytokines that would cause the syndrome that we see. And I put here the H-score that we use to identify secondary HLH, even pre-COVID, that was recently republished in the Lancet article, kind of to help providers identify this disease. Although it's not exactly like secondary HLH, but it does have some very similar features in that the inflammatory markers are very elevated, and you have a new organ dysfunction that was not present previously. We were working very closely with the floor teams that had a lot of intubated patients, and we would help them select patients who require treatment. The mortality is pretty high without treatment, and the treatment that we used was based off of the HLH 2004 protocol. So basically immunosuppression, and we would use steroids for that, usually methylpred, 1 to 2 milligrams per kg. We would use the IL-1 inhibitor, anakinra, or the IL-6 inhibitor, tocilizumab. depending on what was available. We also had multiple studies with other monoclonal antibodies that we were using. The key was to select the appropriate patient, because new fevers with shock could mean a bacterial infection, and the worst thing that you could do during a bacterial infection is to suppress the immune system. So we did have a team that was kind of focused on treating these patients with a hyperinflammatory disease. However, the things that we did not see that were sometimes reported from our pediatric colleagues was a rash that we have not seen that being reported in our patients with hyperinflammatory syndrome. And then in regards to cardiac injury, it was reported that about 19.7 to 27.8 of patients had myocardial injury. In this study, myocardial injury was defined as an elevated troponin or an elevated pro-BNP, which is not unusual in sepsis. And just like sepsis, there was a high mortality in these patients with myocardial injury. There were multiple autopsies that were done in patients with COVID-19, and looking at the heart, there was no increased risk of obstructive coronary artery disease that was seen, and there was no virus that was found inside the cell. So we had very low suspicion that the virus itself was causing this cardiac dysfunction, and the suspicion was that it's more likely secondary to septic shock or critical care illness, which we had previously seen in high-risk infections like this as well. Moving on to thromboembolism and COVID-19, which is a pretty controversial subject. There's a lot of studies ongoing right now, but I'm just going to go over what we know so far. So we had already seen lots of these patients coming in with DVTs. We had seen arterial thrombosis. Our CRT machines were clotting to the point where we had to anticoagulate everybody who's receiving CRT. And but there was no solid evidence. There was no study that was done to show us that initially. So we were not anticoagulating anyone. And now we're having more and more studies that show that these patients are hypercoagulable. So this is a study that was published only on the 29th of May. And what they did here is that they had 34 patients, and they did an ultrasound of the extremities on day 1 at admission, and then 48 hours later. And what they found is that 22 patients initially, which is 65% of those patients, had a DVT on admission. 5 more had a DVT 48 hours later, bringing the total up to 79% of those patients had a DVT. When you compare that to a study that was published a few years ago at CHEST, you see that when patients with severe sepsis or septic shock had an ultrasound of their lower extremities, and these are ICU patients, only 37% of them had a DVT. So there is a difference between the two populations. So now we're trying to figure out, how do we identify these hypercoagulated patients who are more likely to clot? And if we do identify them, should we anticoagulate them? And is that going to be beneficial for them? That is still not clear. And the third thing is, if we do decide to anticoagulate them, what anticoagulation would be appropriate, and what's the least risk that we can do for these patients? And looking at the D-dimers, what a lot of us ended up doing, and you can see even in this study, that patients who did have deep vein thrombosis had a kind of a higher D-dimer at 5.4 compared to those without a deep vein thrombosis, where it was only 3.3. And the study was not powered, and this was not a significant difference. However, this is something that has been shown in some more studies showing that patients who are clotting do have an elevated D-dimer compared to those who are not. And then this is a study that was published in China, where they decided to use enoxaparin low molecular weight heparin at 40 to 60 milligrams daily, or unfractionated heparin 10,000 to 15,000 units daily. What they did is they had 449 patients, I believe, and they ended up, 99 of them ended up receiving heparin, either low molecular weight or unfractionated heparin. Initially, there was no difference in mortality between the two. However, when they corrected for an elevated D-dimer over 6 times the upper limit of normal, that is when they saw the benefit of heparin. So when you look at only the population with the D-dimer over 3, you see that the mortality decreased from 52.4 to 32.8 when heparin was used. Based on this, a lot of centers, and this was statistically significant, based on that, a lot of centers started being very aggressive with their anticoagulation, especially if the D-dimer is above 3. However, there's still a lot of questions about this. For example, this was a retrospective study, and there's definitely selection bias in selecting the patients who will receive heparin as opposed to those who did not. And the second thing is, something you know about D-dimer is it's actually elevated as part of the inflammatory markers. So an elevated D-dimer was found in 46% of patients with COVID-19, regardless of whether or not they had DVTs. A mean D-dimer concentration that is higher was found in patients who did not survive, as opposed to those who did survive. And a D-dimer on admission, well, if it's greater than 1, made you like 18 times more likely to die during this admission than a normal D-dimer. So D-dimer is already known to be an inflammatory marker and a bad prognostic indicator. So should we really be anticoagulating everyone just because they have a D-dimer? Unfortunately, we have seen cases where patients passed away with intracranial hemorrhage. We have had massive GI bleeds because patients were anticoagulated. And currently, there's no solid evidence that anticoagulating all these patients is going to be beneficial. We're still looking at TAG, we're looking at other ways to try to figure out these high-risk patients. But in the meantime, what we're doing at Montefiore Medical Center is that we're looking at all patients with a D-dimer above 3 who enter the ICU. And all these patients get an ultrasound of both the upper and lower extremities and an echo of the heart. And if we see any sort of evidence of thrombosis, then we start full-dose anticoagulation. We're looking at the heart for RV dysfunction, for risk of PE. So we start full-dose anticoagulation in those with high suspicion or with confirmed DVTs, and we'd start with low molecular weight heparin at 1 milligram per kg Q12, or a heparin infusion depending on the creatinine clearance. If they do not have any evidence of DVT, then we do not start anticoagulation empirically. We would start prophylactic doses, which is enoxaparin 40 milligrams daily, or heparin 5,000 q8. There are some centers that are using TPA, and they have seen some benefit to that, to using TPA in severely hypoxic patients. However, there's still no solid evidence that this actually helps. So the only time we do use TPA is somebody who's acutely deteriorating, meaning that new RV dysfunction or cardiac arrest where we suspect a PE. Other than that, we haven't really been using TPA at all. And that is all.
Terrific. Thank you.
Thank you. Thank you very much.
So again, we'll be having questions at the end. Please use the questions caret on the side of the GoToWebinar panel. And with that, we will transition to Dr. Spinella, who will talk with us about monitoring the hemostasis parameters in these patients. Thanks, Dr. Spinella.
So I'm going to provide a more conceptual talk about hemostasis monitoring and therapeutic concepts to reduce thrombotic complications. No disclosures related to this presentation. So what I'm going to do over the next 10 minutes is summarize the pathophysiology of COVID-induced coagulopathy. And as you've been hearing, this coagulopathy is a bit different than DIC. I'll discuss hemostasis monitoring, and then end with goal-directed thrombosis prophylaxis or treatment. So here's a cartoon that we've developed to show the pathophysiology. And you can see up top with the SARS-CoV-2 infection that infects endothelial and epithelial cells throughout the body. You clearly get a very prominent cytokine storm. There's leukocyte complement activation as well as direct endothelial injury. Each of these three processes exacerbate each other, and they all can lead to a procoagulant state. The procoagulant state has been characterized by increased platelet activation despite low normal platelet concentrations. There's a presumed increase in thrombin. I haven't seen any studies that have directly measured thrombin, but the increased D-dimers makes, I think, people presume that thrombin is increased. There's been some evidence of increased factor H, von Willebrand's factor, clearly increased fibrinogen and D-dimers, and also at least, well, 2 or 3 papers showing reduced clot lysis, presumably due to increased PI1. This procoagulant state can lead to multiple organ failure as a result of diffuse microvascular thrombi, in addition to macrovascular thrombi leading to arterial and venous thrombosis. So if we want to prevent or treat thrombosis, I think it's real important to accurately monitor all aspects of hemostasis, not just 1 or 2 parameters. and then develop therapies that are directed at the patient's individual response. I'm not a believer of one size fits all when it comes to treating critically ill patients. And I think that's very true here when it comes to COVID-19. So monitoring hemostasis, as I think you all know, is incredibly complicated. And you know, in the past few decades, while others have narrowed it down to a platelet count, PT, PTT, et cetera, and it's way more complicated than that. This is a very complex in vivo process that is almost impossible to measure with in vitro assays. But what we've been doing, especially with this syndrome, is we've been measuring D-dimers, and this is a very good reflection of fibrin degradation. But again, it doesn't indicate the source of the hypercoagulation. So if we're going to provide goal-directed therapy for patients, directing care according to D-dimers really, I don't think is going to cut it in the end. For PT-APTT, you know, not that it's being used to measure hypercoagulation, but it clearly wasn't developed to do this. If anything, if a patient becomes consumptive eventually, these assays can reflect a hypocoagulable state, but mildly to even moderately elevated PT-APTTs can be misleading. There are many studies showing, including in the COVID-19 population, that with mild to moderate elevation, these patients are very pro-thrombotic, and I think this is partially due to the fact that PT-APTT is a plasma-based sample. Platelets, white cells, red cells are not part of the sample when that assay is run, and when you take those cells and platelets out of the sample, you're taking some of the main players that affect hemostasis out of the equation, and that can lead to misleading results. With the fibrinogen concentration is a good assay with the Klaus method, if that's what your hospital is using. And it's an indirect measure of fibrinogen function. But when it comes to the anti-10A assay, which is what many or most people are using to titrate Lovenox or heparin therapy when they're using an assay, and I realize this might be, well, I know this will be controversial, but the anti-10A assay, I mean, all it really does is provide the magnitude of 10A inhibition, right? It provides the drug effect. It doesn't provide the net thrombin production or reduction in thrombin after you start the drug. It doesn't reflect the effect of the drug on the entire hemostatic system. And when you start an anticoagulant, that's what you really need to know. I mean, the correlate that I always explain to our trainees is when you start an epinephrine infusion to improve cardiac output in the patient, we don't ever measure epinephrine levels, right? We look at the patient and we look at the effect of the epinephrine on cardiac output and then titrate our dose. It's interesting how we've gotten to the point with anticoagulation where we're using anti-10A to titrate dosing. And as a result of what I'm saying here, it can lead to a patient still having thrombotic events because you're not giving them enough, or you're giving them too much and they have bleeding complications. I think there's a better way, and that better way might be the use of viscoelastic assays, whether it be TEG or ROTEM. These are both just different devices. They work slightly differently, and they use a whole blood sample. As a result, platelets, white cells, and red cells are all within the sample being tested. And the assay can give you information related to thrombin fibrin formation, fibrinogen function, as well as platelet function and fibrinolysis. Here's a cartoon of a standard TEG curve. And here the R time reflects the time to initial fibrin formation. If you were using any drugs that inhibited 10A or thrombin, you would expect the R time to be prolonged. The K time reflects fibrin cross-linking or fibrinogen function. The NA is overall clot strength, which predominantly reflects platelet function. Then the LY30 is the percent of lysis 30 minutes after the MA, and that reflects fibrinolysis. When it comes to the hemostatic effects of COVID-19, the other speakers have summarized this, but again, There appears to be mild to moderate increase in thrombin formation, very high fibrinogen and D-dimer concentrations, a low normal platelet count initially, although with the pediatric multi-inflammatory system, the platelet count does increase over time. There's high platelet function despite lower platelet number, and there's reduced fibrinolysis. Now, these are the three reports that I've been able to find that have used thromboelastography to characterize the coagulopathy in these patients. And each of them show an elevated TEG-MA representing high platelet function, elevated TEG-alpha angle, which you'd expect with high fibrinogen function, but also reduced LY30, or what some have called fibrinolytic shutdown. And these have each been associated with increased thrombotic events. The way I monitor critically ill patient in the ICU, these are the labs that I get, very similar to what others have suggested. It sounds like some are starting to use TEG with platelet mapping. I use it routinely. And of course, if patients have a worsening trajectory or thrombotic complications, getting a thrombin protein C, antiphospholipids, etc. The way I approach anticoagulation in these patients is in a goal-directed fashion that's based upon TEG results. The indication and titration of 10A inhibitors, antiplatelet agents, and even fibrinolytics can be indicated and adjusted according to TEG. And if you get daily monitoring with TEG and all of the other hemostatic parameters that I mentioned before, I think you can optimally anticoagulate without going too far and leading to bleeding complications. So what are the future or current therapeutic targets according to the pathophysiology of SARS-CoV-2 infection? Heparin for the increased thrombin, platelet inhibitors for increased platelet activation. You know, potentially the use of TPA to improve clot lysis. I think it's an interesting potential approach that needs to be studied. Plasma to reduce the procoagulant state, as well as addressing endothelial injury. You know, most people think about plasma as a pro-hemostatic agent. That's because you're giving it to a patient who's bleeding typically. But plasma is a balanced solution. If you give plasma to a hypercoagulable patient, you'll actually make them more normal coagulable. And there's also decent evidence in the trauma world and in animal models showing that plasma can directly reduce endothelial injury by reducing gap junctions and improving glycocalyx restoration. If a patient has low antithrombin protein C, those can be supplemented. We've talked a bit about the immune modulators as well to reduce the cytokine storm that really, I think, is a main inciting event of the procoagulant state, and of course, the antiviral therapies. So in conclusion, COVID-induced coagulopathy is a multifactorial hypercoagulant state characterized by increased fibrinogen function, increased platelet function, and reduced lysis. I think we should, in general, be more liberally using 10A inhibitors as well as antiplatelet agents in all patients, not just the pediatric patients with multi-inflammatory syndrome. And with serial global functional assessment, this will allow for optimal anticoagulation and titration of antihemostatic therapies. Thank you.
That was fantastic, Phil. Thank you so much. So that concludes our 4 fabulous presentations. And I'm going to turn this over now to Lincoln and to Don, who will each alternate questions to our speakers for the last few minutes. And we're probably going to go over by a couple minutes, but so we hope if you can hang in there for a few minutes after the top of the hour, that'd be great. But in the very meantime, we have another 5 minutes to our scheduled conference. So Lincoln, I see your face. Do you want to start with a question?
Yeah, I think I'm going to work backwards a little bit since Phil just spoke, and there's a handful of questions regarding both bleeding and coagulation management. So why don't we just start with, for Amira, I think especially, did you see increases in hemorrhagic stroke in patients who were treated with anticoagulation?
Yeah, so we did see a couple of cases of intracranial hemorrhage. We saw, and this was in the beginning of the pandemic, we unfortunately had 2 patients who had intracranial hemorrhage when we started pretty aggressive anticoagulation in all our patients. And that's why since then we've kind of cut down to only anticoagulated patients who do have evidence of DVTs or have evidence of thrombosis. And that is based on there's currently no solid evidence to empirically anticoagulate everyone. So I wouldn't say it was a dramatic increase in the rate of ICH specifically because we had thousands of patients. We did see a couple of injuries.
And then I think for both you and for Phil, there was a couple of questions regarding either an algorithmic approach or specific cutoffs in INR or other lab values that you would use to direct or guide anticoagulation. And I think to some degree, maybe Phil addressed this in terms of using something like TEG or ROTEM to provide a more individual response rather than an algorithmic response. But if either of you would like to comment on that, that would be helpful to the audience.
Well, to be fair, I think really the question, even if you're using TEG or ROTEM, there still needs to be a threshold, right, for the indication of a drug and then the titration. And that's the problem with all of the hemostatic assays. When it comes to anti-10A, it was basically made up, right? You read the CHEST guidelines, they virtually say that. They do. I know you're laughing, I hope because you agree. So when it comes to like a TEG-R time, right? You know, I kind of use my experience and the risk of the patient of having a significant bleed, and I adjust it, you know, but it needs to be, I think, in the 12 to 14 minute range if you're going to try to truly anticoagulate a patient. For the TEG-MA, I think I'd like to see a good 60–80% inhibition on the platelet mapping, as long as the TEG-MA is not incredibly high. I mean, that's the problem with implementing kind of a TEG or ROTEM approach, is that people have to get really familiar with the assays and know what they mean and talk to others. It's taken me 15 years to kind of get where I am with being comfortable using it. And, you know, culture change is hard. And especially when things are stressful and you're wearing PPE and donning and doffing, and no one wants to deal with the TEG or ROTEM interpretation. But I think it's the way forward because it's a more functional assay that can give more information. We have to spend the time and figure it out.
There's a couple of questions probably for our New York colleagues. Other than IVIG, what other immune modulators are you guys using? Are they responding to for the population that you're seeing in New York?
As we mentioned, the majority ended up coming to the ICU, particularly earlier on. And by our algorithm's definition, those were classified as higher risk patients. And really high risk referred to the risk of developing coronary aneurysms. And I'm looking at Christine down the corner here to make sure she's nodding with me and agreeing. And all those patients, besides IVIG and aspirin, they all received some different dosing, but guaranteed they got steroids as well. And frankly, the patients, so they're all on aspirin, IVIG, steroids, and the vast majority really responded quite well fairly quickly within 20, you know, it was not uncommon that a child on norepinephrine was off within 24 hours of presentation to the ICU. So it's really a quick turnaround. So that was a standard approach, and only if they still were febrile after IVIG had been done for 24 hours and on steroids would we even consider a biologic modifying agent. Dr. Capone?
I completely agree. We really used and reserved the biologics for persistent inflammation or worsening echocardiographic findings of dysfunction or development of a coronary aneurysm 24 hours even after IVIG and steroids.
Yeah.
And we went to anakinra, which is unusual in Kawasaki, but can be used in macrophage activating or secondary HLH, which can come with a Kawasaki shock phenotype. And so that's why we went, given our ferritin levels being so high and some of the phenotype overlap with anakinra. And it is used as an adjunct to the Kawasaki, so we built off of that literature to come up with that particular biologic.
There was a question from Pakistan. Are these patients presenting afebrile? Do all of them have fever or are they afebrile?
I think that was one of the entry criteria is minimum fever of 24 hours based on CDC. Our cohort was 4 days, although we started identifying kids, or at least screening kids even less than 4 days, but they all universally had fever as one of their presenting symptoms.
I'm shocked with the adult perspective on these temps up to 107.
Yes,
That is pretty impressive. The one one of my MIS-C patients, she presented, she went up to 42. So what's that? Also very high.
Yeah.
She was a teen. She is a teen.
We had 2 patients with a temperature of 109, and both of them were under 30 years of age. So I think that probably the younger population can tolerate a higher fever. But yeah, we've seen 107, 105, 109. So.
I added in the answer to that question, there's a recent JAMA publication by Whitaker describing a patient series in England, and at least in that, 100% had fever. But this was a mixed cohort of both active COVID and post-infectious syndromes. So I think that's a little bit harder to interpret. I want to ask, there's a handful of questions that I think are related to treatment questions regarding anti-inflammation or immune modulation. And it was regarding neutrophilia and neutrophil to lymphocyte ratios in the patients that have shown up. So I think I'd first like to ask Amira, what have you seen in adults? Did you see or observe any patterns with neutrophilia or neutrophil to lymphocyte ratios?
Actually, most of these patients are leukopenic and sometimes pancytopenic. So there was a lot of leukopenia. Neutrophil count itself was most of the time close to normal. And I think that was in one of the slides that I didn't talk about it, but the characteristic labs for the New York City cohort, most of them had pretty close to normal neutrophil level, but the lymphocytes were decreased.
And James and Christine, how about in kids?
Oh, okay, so for active SARS-CoV-2 infection, we have not seen any association with leukocytosis and outcomes. One of our colleagues has done a study and they looked at CRP and ferritin, and that was associated with severity of illness, increased length of intubation, and multi-organ dysfunction, and hopefully will come out. It was sent to critical care. But we haven't seen that outcome data for MIS-C. And as a matter of fact, in MIS-C, they do have an elevated white count, but what the predominant finding is profound lymphopenia. And that lymphopenia is unclear what the outcomes are, because the majority of patients, as we talked about, do better, and they get better pretty quickly. Even the ones who have been on ECMO when the study's out there, none in our center, but again, out there, they do resolve with supportive care and immunomodulators. So because of that, the long term is going to become important. Those who resolve their dysfunction, do they end up with a diastolic dysfunction like Kawasaki shock in the long run? And do they develop coronary abnormalities? And then we can look back at those patients and say, what were their risk factors that were associated with that severity of illness? But until we have that epidemiology, right now, majority are surviving, which is fabulous. And actually less seem to be needing the ICU towards the end of this as the awareness has increased, because they're getting picked up sooner, getting screened sooner, awareness is there, pediatricians are referring. And so it's a treatable illness. And the question is, how do we treat it? And a lot of that, I think, speaks again to the immune modulators. Some centers are using less, some are using more because we don't have the evidence for it. We know that there is more CRP, there's more ferritin than in MIS-C, than in toxic shock, than in Kawasaki shock. But what does that mean? And does that mean that treated aggressively? And I think when we look back at all of this with hopefully good collaboration, we'll be able to look at who has the coronary abnormalities, who has the diastolic dysfunction, and see who and how they were treated, and if there were some lab abnormalities that could have tipped us off to identify high-risk patients.
Lincoln, if I may, the one thing I'll just say with the lymphopenia is that I think what it's doing is, in my experience, in my mind, is that it helps to identify which child may actually have MIS-C or may have acute COVID. It's more of right now, it's more a diagnostic indicator to kind of gear me in the direction of COVID-related illness rather than some other thing. Because the one thing we have to be mindful of is not to have blinders on, that a child doesn't have good old-fashioned septic shock from some other organism, which looks very similar.
And I think that kind of leads to some of these next questions regarding management with either leukapheresis, apheresis, other immune modulators, regarding treatment of, quote, cytokine storm versus the MIS-C. And again, maybe start with Amira, if you have some thoughts about how you either are managing this differently as compared with things like toxic shock syndrome, or maybe adult patients that you're seeing who are treated with CAR T cells that get a version of cytokine storm.
So I think because this happened during the pandemic, and we had thousands of patients at the same time, unfortunately we did run out of a lot of our monoclonal antibodies that we initially started off using pretty aggressively. When you see patients kind of deteriorating pretty rapidly, and this is just what I have noticed, is that it usually happens day 5 to 10 of the illness. So they've been sick for a few days, admitted, and then day 5 to 10 is when we get a call that their temperature is not coming down, they're requiring pressors, and they can't oxygenate them anymore. So initially what we started doing was steroids was first line, and the floor teams would usually order the steroids, and then the second line would be a monoclonal antibody. We have used IVIG, however, it came second, and that's different from what we would do pre-pandemic, but the IVIG we used kind of later, and I think it was just due to availability of the monoclonal antibodies. We had multiple clinical trials that were ongoing that were available to us kind of a lot more quickly. So a lot of these patients ended up getting some sort of interleukin inhibitor, and we would see improvement in at least the clinical picture. So we would see the temperature coming down, we would see the pressor requirements slightly improve. If we don't, we do redose those patients with a second dose of monoclonal antibody. However, unfortunately, in my personal opinion, in our ICU, the mortality was still pretty high. And even those patients who were able to treat the syndrome, who did, quote unquote, recover, they did end up not getting extubated and kind of ended up with a trach with a very poor mental status. And I think that's partly because of the severe inflammatory response probably has, and the severe hypoxia as well. It's very hard to ventilate and oxygenate when they're going through this period. So although the mortality even pre-COVID was reported as around 25% in viral sepsis, which I believe between 18 to 25, even I think during the COVID era, probably because of our lack of resources as well, it was, I would guess, a little bit higher than that. And the outcome was not usually as well as we would hope. So we would start with steroids, and 100% of patients got steroids. It would be at least for 5 days, usually for 7 days. And then monoclonal antibodies came second. IVIG was last, and that would be if somebody doesn't respond to the monoclonal antibody.
James, you can speak more to the acute COVID part of it, but for MIS-C, we really kind of focused on the IVIG and the steroids, kind of going to what we know in the Kawasaki literature and trying to extrapolate, because there are so many overlapping features, and that is what we knew, because there is no evidence for this. When we reached for a biologic, anakinra came to play because of the ferritin and the association with secondary MAS. It's also a little bit friendlier. It less side effect averse profile, correct me if I'm wrong, Dr. Mohammed, but where toci can actually drop your CRP, but you still can have a lot of inflammation that's ongoing, and you really don't know if you really control the inflammation as well as you ought to. And there have been anecdotal reports of worsening aneurysms actually on toci. So we try to avoid that once we were able to identify antibody-mediated, specifically PCR negative responses.
I think we found out a lot about toci during this pandemic, because I've used it more than I ever have, and it causes apparently microperforation of the gut that was reported in a few studies. And we have seen patients kind of deteriorate after getting toci, continue to be febrile and septic, and then we find out they have some sort of perforation with a bacteremia. So there are a lot of risks with using the monoclonal antibody, and we try to kind of control which patient gets it and kind of help with patient selection. But overall, I think the mortality once the temperature gets to 107 or 109 is pretty high everywhere.
Heidi, do we have time to do one more question?
I think we're at 4:12, so we're 12 minutes over, but if it's a quick question, I think we can go to that, but otherwise I think we'll have to wrap it up.
Okay, I don't know how quick this is going to be, but I think it's important, given the results of the recent recovery trial and the association of dexamethasone as a treatment for active COVID infection being associated with improved outcomes. And I think the observation that the patients who are presenting with MIS-C have leukopenia and steroids cause worse leukopenia, and yet steroids are all being used in the treatment of MIS-C. Does the use of steroids make any of you worried about the effect that this might have on risk of post-infectious syndromes if we're further knocking out the lymphocyte population?
So I'll try and keep my answer brief. No, because these kids are coming in quite sick. These kids are getting multiple fluid boluses on inotropes and vasopressors, and within 24 hours of treatment, which includes steroids, we've had a really remarkable recovery that's specific for MIS-C. And I can tell you from our acute COVID infections in the pediatric ICU, plus many of us in the pediatric world, we were working in the adult side as well in their ICU. And our anecdotal evidence is that those who got aggressive steroids, even for bad ARDS, seem to have better outcomes. So I appreciate their concern, but I think the risk benefit still, to me, leans in favor of pretty aggressive corticosteroids.
And I think that goes to the difference between what you can measure in free-flowing blood as compared to the burden of the activated immune system.
Okay. Thank you. Thank you, everybody. I really appreciate your time and all the effort in putting this together and joining us. And I'm thrilled that we've had over 100 participants, and I know many others are going to look forward to the recording afterward because they sent me email otherwise that they knew they wouldn't be able to attend. So this presentation will be witnessed or heard by many others going forward. Thank you again. Appreciate everybody's time.
Thank you.
Thanks, everybody.
Thank you.
Virtual ATS in the beginning of August, right? Virtual ATS.
Thank you.
Thank you.